We have a team from Hifu and Dr. Moses. Also, kuja hapa. Yeah, we have been having, when we started, our only way of sorting out fibroids was removing the uterus. Then we advanced a bit. We started removing the fibroids themselves. Then we advanced a bit. Some people came in and started doing laparoscopy and even removing the fibroids. Then we advanced a bit and even started doing hysteroscopy and removing fibroids. Then we advanced a bit. Now there are some guys who are saying you might actually start removing fibroids in your office. And Moses will tell us how we can do that. That would be very useful because we as gynecologists can increase our income, but the theater that are taking our money, we at least now the money can come to the gynecologists instead of the theaters. Myomectomy ikisema ni 80 bila theater fees, they are more likely to pay than when it is 300K. No way. Moses, take it on. This is the final one. Immediately after this, we make announcements and people can have lunch and leave at their own pleasure. Thank you.
Good afternoon. I think that's fine. Yes, good afternoon. So my name is Moses, and we'll basically, this is not a case report at least. It's basically more of a sensitization of more technology that is available to us. And this is actually not new technology. It's technology that has existed for more than 3 decades. It's only that in Kenya, it's inaugural in our center, the Hifu Center. So I'll not bore you with things that you know. I'll probably brush through and then we can spend some more time on the important things. So maybe for the pre-interns, you might pick a few things on fibroids, but I'll not dwell on it much. So in simple terms, fibroids are generally benign tumors or growths in the uterus. So that is to say they are non-cancerous, and the origin is of smooth muscle origin, and they're the most common benign tumors among women of reproductive age. In terms of numbers, the prevalence varies. It's quite broad, and this is basically because of different risk factors, as it were. But generally, they are more prevalent among women of Black descent. The good thing is that majority of the women who have fibroids are actually asymptomatic, but third of them have symptoms, which we are going to see. So in terms of age distribution, they are basically within the reproductive age brackets. And you can see the ages between 20 to 24 and then 30 to 35 to 39, basically where majority of women in reproductive age bracket fall. Risk factors, I think we know a number of them. And I think for our junior colleagues, maybe these are important for purposes of history taking, so that when a patient presents maybe with abnormal uterine bleeding, you know the things that you probably can ask. But in summary, race, genetics, duration of exposure to estrogen. So that's where the issue of reproductive age, early menarche, menopause comes in. Other factors, obesity, and also some lifestyle conditions. So in terms of clinical presentation, the commonest symptom is heavy menstrual bleeding. And this occurs in about 40%. 40% of the women who have fibroids and they present because of symptoms is because of heavy menstrual bleeding. And 20 to 30% have dysmenorrhea. And most of the time, they can also occur in combination rather than singly. Then in terms of grading, when you talk about abnormal uterine bleeding, and I think this we have an idea about, they are different. This mnemonic is old, but it never changes. Palm coin, basically to help you to remember the causes of abnormal uterine bleeding. And L there, leiomyoma, is what we are focusing on, and a bit of adenomyosis. Maybe this one you can check later as well. But why are we interested in management of fibroids? Is because apart from the symptoms I showed you, they also affect the quality of life of women. Many women would miss, maybe they have a lot of missed work days, or even sometimes academic productivity because of symptoms associated with fibroids, as well as affecting their reproductive goals and also maybe their sexual activities as well. Of course, there is the issue of anemia, because we know there is a significant blood loss with the heavy menstrual flows, subfertility and recurrent pregnancy losses, and not to mention the economic implications. These are some of the investigations that you do for patients who have abnormal uterine bleeding, and especially fibroids. So the first line is the basic laboratory test that you do. Complete blood count to check the hemoglobin levels, iron studies, coagulation profiles to be sure to rule out what is causing the bleeding. And then imaging is the mainstay. So ultrasound, ultrasonography, which you can do abdominally or transvaginally. Then MRI pelvis. You can also do saline infusions on hysterography, which has a high sensitivity and specificity, especially for the submucosal fibroids, and HSG, as well as hysteroscopy and laparoscopy. In terms of management, the goals are basically to reduce associated blood loss and to improve quality of life and alleviate symptoms. So the management approaches would include initially to control the blood loss, so tranexamic acid, which is commonly used, NSAIDs, non-steroidal anti-inflammatory agents, then hormonal methods. All these you can use. Then there are traditional surgical approaches, the myomeltomy, which can be open, or laparoscopy, as well as hysteroscopy. In women who have also achieved desired family size, sometimes you can also discuss about hysterectomy, and it can be through laparotomy approach, TBH, or also laparoscopy. I will skip this one. So apart from the hormonal methods of management and the surgical techniques, we know that advent of technology and invention led us to minimally invasive approaches, that is the uterine artery embolization. But as the word suggests, there's still an element of invasiveness, and this mainly is done by interventionists. Interventional radiologists are, keen on this by injecting those particles called polyvinyl alcohol particles to basically block blood supply to the uterus. Of course, the drawback is that this is not a preferable method of treatment for patients who are desirous of fertility, but otherwise it leads to gradual shrinkage of fibroids because of the limited blood flow and resolution of symptoms downstream. So this is basically an illustration of the UAE, which is not the topic I'm discussing. So I will skip it, but maybe you can read more on it. Then let me now go to the meat which we want to discuss. So as you see, the evolution of treatment of fibroids has evolved from medical, surgical, minimally invasive, and currently to non-invasive, what we call high intensity focused ultrasound, or basically Hifu. So before I go to what Hifu exactly is, the Hifu technology can be applied to treat fibroids, adenomyosis, basically solid tumors, as well as, like for us, maybe gynecologists, placenta accreta, spectra after delivery, that is, cesarean scar pregnancies, and also scar endometriosis. But generally, more than 90% of the centers, they manage fibroids and adenomyosis, and scarcely the rest. So as the name suggests, high intensity focused ultrasound uses basically high frequency ultrasound waves. So the same ultrasound machine we use, is only that the frequency of this ultrasound is ultrasonic, more than 20,000 kilohertz. And generally, a transducer emits ultrasound waves, and then they are focused on a point, which is basically a focal point, which acts as the ablative point, or more like a cyber knife. And this convergence of the ultrasound waves, as we're going to see, leads to thermal concentration that it hits to a point of about 65 degrees Celsius, sometimes up to 100. And this is the ablative point, which causes coagulative necrosis on the tissue, or the tissue that you are targeting. In this case, we are talking about fibroids. Now, different machines over the years have been calibrated to ablate different widths. The one we currently use ablates to width of 5 millimeters. So it's basically that when you fire energy to a lesion, let's say a fibroid, it's going to ablate 5 millimeters. And that is to mean that for you to actually ablate the fibroid, you have to do multiple points. Now, these multiple points, you can do them sparsely or you can do them in a linear dimension. Of course, it's more organized to do them in a linear dimension so that you ablate different points. You create maybe a line of an ablated area. You create another line so that eventually you can ablate several slices of a fibroid. And I'm going to show you a small video. Now, this leads to coagulative necrosis and damage of the blood supply around the fibroid, and eventually the fibroid shrinks and symptoms resolve. The reason I brought this slide is because since we began this work, we encounter a lot of people asking who are the patients who actually fit or who can be done this Hifu. Generally, these are the patients who are in the reproductive age brackets, but preferably younger women, maybe between 20 to 50 years. We try to avoid older women, maybe the 60s or the postmenopausal women, because remember, when you have big fibroids among this cohort of patients, there is also a risk of sarcomatous transformation of the fibroids. And you see, one of course, the drawbacks of this technology is that you do not have tissue histology, which maybe for older women is important, just like for younger women. Of course, good general health, that is to mean if they have other comorbidities, like let's say blood pressure, diabetes, they need to be well controlled. Now, in terms of the size of the fibroid, this is important. Generally, all fibroids can be ablated. The only question is how safe is it to ablate maybe the smaller fibroid, because you realize that for fibroids, let's say, which are in the submucosal fibroids, for example, it means that if they are very small, if you give energy, there is risk of dissipation of this energy, and it can actually cause thermal damage to the endometrium. So for a woman who is maybe desiring fertility, if you damage the endometrium, then that's a challenge. If you're talking about, let's say, subserosal fibroids, if they are very small again, it means that there is a risk of this thermal energy spreading to nearby organs. And what would be the nearby organs? Of course, bowel. If you ablate the bowel, you cause fistula, which is not what we want to do. So generally, fibroids which are 2 centimeters and above are what we consider good candidates, and especially the intramural fibroids. I've already indicated that this thermal knife ablates to a width of 5 millimeters, and it is generally considered that to leave a margin of about 15 millimeters, that's a safe margin. So you see, you ablate 5 millimeters, but also leave a margin of about 15 millimeters around. So this figure really basically to say the location of the fibroids, and in simple terms, without complicating, the most preferable fibroids are the intramural. However, for the subserosal and submucosal, if they are bigger than 2 centimeters, then you can also give them energy because you still have a safety margin. The number of fibroids does not preclude treatment. This is also another question I've seen frequently. How many fibroids can you ablate or can't you ablate? You can ablate, a woman who has one symptomatic fibroid, you can ablate that fibroid. If you have 10, 20, the only question is, are you able to access these fibroids during this process called simulation? So before ablation, we conduct what is called simulation. It's basically a planning stage to map out the fibroids and also determine safety, because you want to be sure that when you fire the energy, it's only going to the targeted lesion and it doesn't cause injury to the surrounding organs. And maybe the beauty is that it's not a must that you have to ablate all the fibroids in one sitting if the patient has multiple fibroids. You can discuss with the client to have maybe repeat sessions later if it's that maybe ablating fibroids is going to subject the patient to excessive energy. Generally, we want to give energy between 3600 joules, so we also have to balance that. Postmenopausal women, for the same reasons that I mentioned, then uncontrolled medical conditions, because as you're going to realize, as we do this ablation, the clients are usually under conscious sedation, so there's a medication that they are given, and they're also to remain in prone position for 2 hours of treatment and 2 hours post-treatment. So patients who have uncontrolled medical conditions sometimes might be a challenge to maintain those positions, or even to drug interactions, because sometimes you use maybe atropine to control the heart rate, or also even the sedative medications. Of course, we can't give this energy to pregnant women for obvious reasons. So basically, this is the concept. I want to believe that maybe all of us had a chance to do this in our science classes, to focus sun rays to a point to burn a paper. And this is exactly the concept of Hifu. Basically, ultrasound waves from a transducer, they converge. So the transducer is basically a convex, is it convex or concave? Yeah, lens that focuses the ultrasound waves on a point. And this point is what generates thermal energy and ends up ablating or basically burning the fibroid. So this is exactly what I was talking about. I don't know whether this can it point? Oh, I don't know. Oh yeah, it looks like it can, yeah. So you can see this is the transducer here, and because of the curvature, it focuses the ultrasound waves to a point. Now this point is what heats up to about 65 to 100 degrees Celsius. These are ultrasonic waves and generates thermal energy. Now this point is the hot point that ablates 5 millimeters width of tissue. So basically what you see here. So the client lies in this position, in a prone position. The transducer is here, and I'm going to show you the machine so that it makes more sense. So the transducer emits ultrasound waves that converge to a point within the lesion. So this yellow thing here is the fibroid or the lesion, and the red bit is the ablative point. Then you do this on multiple points until you form a line of ablated areas, another line, and eventually a slice. Then you create a whole volume of a fibroid which has been ablated. So generally, this is what I was talking about the knife basically hitting to a degree of 65 degrees Celsius. Then when you subject target tissues to this kind of temperatures, there is a coagulative necrosis that occurs, then the gradual shrinkage occurs, and of course, the body's immune system is also able to resorb the residual tissue. The beautiful thing I have to mention is that as you do ablation, you do it real time. So you can to tell what is called grayscale changes. So when you ablate a tissue, there are some grayscale changes that usually occur. I think one of the slides is going to show that. So that by the time you can actually be sure that to ablate as much as over 80% of the fibroid, what we call the non-perfused volume ratio. You're able to calculate that during the same sitting so that if you achieve 80% of this ablation, then you can always continue to ablate until you achieve that. And that is what is considered satisfactory. So basically, this is what I think you are describing. This is oxygen. So you can see when this energy is focused here, it causes this kind of change, multiple points, then more than 80% of that tissue is going to get ablated. And this is basically what I was trying to describe there. So you can see this is liver. So it's ablated in small bits. These things coalesce, they become aligned, so it becomes linear. Then eventually slices so when we map out the fibroids, the machine or the panel slices the fibroids into different slices, which are 5 millimeters in width. So you ablate slice-wise. So every time you ablate, you ablate a point within that slice. So you ablate as many slices as possible, but leaving a 15 millimeters margin on the outer to avoid injury to surrounding organs. And eventually you will see this extensive change on the tissue, and that's what happens to the fibroid as well. So this is basically the concept of point ablation, different points within a slice, and then you'll have multiple points, then different slices. And as you can see on this demonstration, this is one slice, another central slice, a third slice. When all of them are ablated, then you can be sure that if let's say you have divided a fiber to, let's say, 10 slices, you ablate maybe 8 slices and leave a slice on one side and a slice on the other side, you probably will have achieved more than 80% ablation rate. So before this procedure, of course, as I said, we do what is called simulation, basically mapping out to determine the location of the myomas and the number of the myomas and establish a safe acoustic pathway to be sure that other intervening vital organs are not along the way. Prior to this, patients have to do a pelvic MRI. This helps in terms of determining the number of fibroids, the location, but also more importantly, grading in terms of vascularity.
So hyperintense lesions are highly vascular, and that would mean that some of them might require a different sitting ablation. But if they are low intensity vascularity, then you can ablate sitting. So there is this Funaki grading 1, 2, and 3 based on blood supply. So Funaki 1 and 2 are basically moderate vascularity kind of fibers. The Funaki 3 is basically highly vascular fibers, or the hyperintense T2 on the one. Then bladder training for the clients. We advise the clients to try and hold urine as much as they can, because as you can imagine, the bladder gives us an acoustic shadow when we're trying to see the uterus. So for the patient to remain 2 hours in prone position without moving, they would generally have to train their bladder to hold urine for a longer time. Then generally, the patients should not be bleeding and should not also be pregnant, and of course, bowel preparation to avoid injury. Now, bowel preparation entails giving laxatives and changing diet to maybe easy to digest foods 3 days prior to the procedure. So this is the setup. So this is the bed where the client lies. Where you see these blue linings is where we have a water tank, which has degassed water. Then there's a transducer within that tank and an ultrasound probe. Then this is the panel. So this first screen here, we mount the MRI that the client has done, both the T2 and T1 weighted images to be able to determine the size and also the vascularity. Here we indicate the patient's clinical data. This is the treating ultrasound, the treating screen, where we basically establish a treatment plan, and it is also the screen that fires the energy. Then this screen basically is controlled by this ultrasound. So as we ablate, we are able to see that fibroid on this screen. And we just use these keyboards here to control both the bed, the transducer, as well as the probe. So the client lies in this position. As I had mentioned, the bed looks like this. This is a water tank, the blue console inside there. We fill it with degassed water. The degassing process is somewhere inside here. The client lies in a prone position in such a way that the pelvis lies directly opposite this transducer. However, this transducer can be moved in different directions, both up and down, and also on the sides, basically in AP and also in different dimensions, as well as the probe. And this is basically to target the different fibroids of the uterus, as well as different slices on the fibroids. So on the treatment screen, this is how it appears. So this is an acoustic pathway, basically the treatment channel, what looks almost like triangular there. This is the focal point, or the thermoablative knife, if you may. So when you ablate this point, it becomes grayish. Maybe the gray changes here are not as adequate, but initially it is maybe hyperintense or hypoechoic, and then they turn gradually to grayish coloration, meaning that you have actually ablated the fibroid, and we do that continuously. I think this is clearer. So this is the ablative point. This is the acoustic pathway or treatment channel, and these are the grayscale changes that you're talking about. So we do this on multiple points until the majority of the fibroid actually has these grayscale changes. After treatment, which is also another plus for Hifu, we inject contrast. This contrast is essentially to show us what is called the non-perfused volume ratio. So after conducting the ablation, a fibroid will appear this color, basically totally black. If it has these microbubbles going around it, it means that it is not fully ablated. But once it changes to this color, after injecting the contrast, then we are certain that the fibroid has been ablated. And this is real time. Once you finish the ablation, you infuse contrast, and then there's this changes. If you measure and it's less than 80% of the initial fibroid, then you have to continue doing the ablation until you achieve that. So this contrast is called Sonoview. It has some sulfur particles. I think I'll remember the name. I will share. So this is basically a demonstration of a client who has been who has undergone a Hifu treatment, and you can see initially she had a Funaki 3 kind of lesion, which underwent Hifu ablation, then gradually shrunk and eventually disappeared by the time you're at 18 months. Usually clients who come with symptoms, they have resolution of symptoms within the first 6 months. Sometimes clients will have changes in their maybe menstrual flow, pelvic pressure symptoms within the first 3 months of treatment. I don't know, is it moving? What has happened? I don't know what has happened. It's not, okay, sorry. I don't know, it seems to. Yeah, okay. So this is a client who also underwent ablation of a submucosal fibroid. Usually because you kill off the blood supply, sometimes they also tend to slough off. And one of the things you have to tell a client is to maybe observe for heavy bleeding initially or a vaginal discharge, or even sometimes passing of the fibroid vaginally. Then this is a client who had but this one is not from our center. This is a client who had adenomyosis on the anterior and posterior uterine wall, and she underwent ablation. Generally, Hifu is best for focal adenomyosis as opposed to diffuse. I have to mention that because, as you can see, it's ablating a solid confined area as opposed to firing aimlessly on the uterus. Unless, of course, the patient wants endometrial ablation. So this was ablation of, so during training, at least we observed, I think, one scar endometriosis being ablated. Now, this is not very common, as well as cesarean scar pregnancy. So this was a case of an endometrioma, and it shrunk after some time. This was a case of, I think I only observed only one cesarean scar pregnancy ablation. So why Hifu? And I think I'll echo what Dr. Kigondu was mentioning. So this technology is not meant to take away bread and butter of gynecologists. If that was the case, even myself, I don't think I would be interested in it. But basically it's to broaden the options for clients, because different clients have different clinical profile, and different treatment approaches would fit them. For example, this week there's a client we received from one of our senior colleagues, a client who has symptomatic uterine fibroids, but this is a client who has, for such a client, as long as the pulmonary embolism, and also has systemic lupus erythematosus. So she's not a very good surgical candidate in that sense, and she has symptomatic fibroids. So as an obstetrician, you are left with the dilemma of, do I go to theater to alleviate the symptoms of this client, but do I also take this surgical risk? And you know that she's a high-risk candidate for surgery. So for such a client, as long as for instance, this client has been on anticoagulation, she's been on follow-up with a cardiologist, as long as we get a good, clean bill of health, that her heart function is perfect, her pulmonary functions are okay, she's a candidate who we can actually consider to do ablation. But of course, as you realize, it's also a multidisciplinary team, because we also have to work in collaboration with a rheumatologist and a cardiologist for that specific case. So basically it is to broaden the option for patients, and probably to give patients options that give them the least possible complications. So one of the advantages is, of course, the fact that it is non-invasive and there's no blood loss involved. If it's non-invasive, also the likely surgical complications are also heavily minimized. Low anesthetic risks, because as I had mentioned, we only use conscious sedation so that the client is awake during treatment. They can tell us maybe if they're having excessive discomfort. It's also safe, effective, and also has less complications, like I mentioned. And the reason for this is because it's real-time ablation. It's not blind ablation. You can be able to see where the focal point is, and you cannot fire energy unless you've seen the focal point within the myoma, and that is usually the advantage. The other thing is that it is repeatable treatment. For example, I'm sure most of us have operated on women who have leiomyoma, And maybe 3-5 years down the line, they come back with recurrence of the fibroids. And at the back of your mind as a clinician or as a doctor, you know, any subsequent surgery has more technical difficulty, or even the complication rates increase. For clients who undergo HIFU, if they need, it doesn't mean that they can't get recurrence of fibroids, because you haven't eliminated the risk factors why they got the fibroids in the first place. But you can always schedule for repeat sessions in the future without necessarily increasing the risks or complications, because again, you only focus on the myoma and not on the surrounding tissue. It's conformal. Then patients have quick recovery time, because it's basically a day procedure. The client comes in the morning fully prepared. The procedure takes about 2 hours. They have a 2-hour resting period. Then they are discharged home and they are able to be followed up within 2 to 4 weeks. Then of course it's preferable for women who desire fertility as compared to something like, for example, uterine artery embolization. There have already been HIFU babies or women who have conceived after HIFU, and generally the recommendation is to try to conceive at least not less than 6 months after the HIFU, because remember, you're also taking time for the fibroids to actually shrink, and shrinkage is best in maybe from 3 months, 6 months, and maybe by 1 year you have satisfactory shrinkage that can allow safe carrying of a pregnancy. So in terms of rates of shrinkage, this is data based on a different center. From the women that they had done HIFU, by month 1 post-procedure, generally there was a 46.9% shrinkage of the fibroids. By 3 months, about 57%, and by 1 year, about 75%. Generally, when you ablate or you kill off a fibroid to a 75% reduction, mostly the symptoms are also going to resolve. Then we do follow-up MRIs to be able to determine whether there is adequate shrinkage. This is done at least from month 3, 6, and also maybe at 1 year. As I mentioned, the sole purpose of treating is to alleviate the patient suffering, and we assess this using the quality of life scoring tool for fibroids. And as you can see, after HIFU ablation, the quality of women, these women who are being evaluated here, improved significantly. But this question, I know we will want to ask, so I will shoot it up front. One of the complications that you could anticipate maybe would be skin burns. Maybe that's the most important one to discuss, but again, the prevalence rate is less than 1%. And this is simply because of the mitigation strategies. Remember, I mentioned that when you're doing the ablation, the patient's skin is in contact with cold degassed water. That's number 1. Number 2, the hot ablative point is the focal point where the ultrasound waves converge, but the rest of the pathway has minimal energy. So the risk of causing damage to the skin is also very minimal. Bowel injury is quite unlikely unless you've not done proper simulation or proper preparation. And the same case with a bladder injury. Recurrence rates, we know, for conventional surgical techniques, the recurrence rate for fibroids ranges from 10 to 30%. And you might need to do maybe repeat surgery or a different approach to treatment. For HIFU, it still retains a recurrence rate of about 15%. But as you can see, we had seen earlier that it is treatable with no multiplication or other additive complication rates when you do repeat ablation. But in terms of fertility, in one center, there's a 47% pregnancy rate amongst 174 patients who are done HIFU within a period of 3 years. So it offers promise even for women who are desirous of fertility. And even in our own center, we've had this collaboration with a fertility specialist for their patients who are maybe on follow-up, but they are found to have uterine fibroids. Okay, so in conclusion, HIFU basically is to empower doctors or gynecologists to have more arsenal for your women so that you can offer them medical management, maybe conservative management sometimes, especially for the small fibers that you don't need to treat. Surgical techniques, the laparoscopy, myomectomy. For those who don't desire fertility, you can also give them the option of UAE if they fit the criteria. Then also HIFU comes in place to give you a broader option of an non-invasive technique that has no surgical complications or basically has a better complication profile compared to maybe the others, and probably more acceptable and convenient for the patient. So that's the panel. Before maybe you shoot questions, let me ask that maybe play a small video. Could you maybe project? It's about maybe 2 minutes. Then after that, I can take some questions.
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focused ultrasound, HIFU, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body, without causing any damage to the overlying surrounding tissues. Ultrasound-guided HIFU involves HIFU ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrate an echogenicity or grayscale changes in the ultrasound images after the sonication, which enables immediate assessment of patients' response to ablation, ensuring a safer and more controllable therapy. Imaging fusion and three-dimension digital reconstruction function provide doctors with a much clearer vision during the whole procedure. Thus, doctors can finish the treatment with an ease. Ultrasound-guided HIFU, a new option for the gynecologist to manage uterine fibroids and other gynecological benign tumors, can maximally preserving the integrity of the uterus. No surgery, no bleeding, and no anesthesia. Patients can even chat with doctors during treatment to ease their tension. Patients can go home in merely 2 hours after the treatment and resume normal life the second day after treatment. Post-operative MRI may still detect the presence of ablated lesions. However, vascularity is now absent in the ablated region, as the ablated lesions will gradually shrink or even disappear over time. The symptoms will also be gradually alleviated or eliminated. Ultrasound-guided HIFU for gynecologists.
Yep. Questions? Yeah. Iko. Microphone. Uko nayo?
Thank you, Dr. Ngoigo, for the wonderful presentation. For me, one of the questions is in terms of when you're looking at, especially if you have either myomas in the anterior uterine wall and maybe in the posterior uterine wall, are you able to adjust the depth of the HIFU? That's one. And with that adjustment of the depth, is there any risk of either injury to the endometrium, especially if you are doing anterior, then maybe you move to the posterior? And then other than the ladder being used as a window for the ultrasound, does it also help in terms of achieving the right dose of depth of the HIFU? Because remember, ultrasound beam travels better in fluid compared to in terms of solid. Then my other third question is, has it been considered is something we need to think about for the treatment of ectopic and surgical treatment of ectopic pregnancy?
Maybe I can answer those, then you can answer. I don't forget. That would be mobile. Sorry. So I think let me start with what Dr. Ikoli had asked first about adjustment. So as you've seen actually in the video that I just played, so the whole of the machine, the treatment machine, is actually controlled from a central panel where there are 4 mounted screens. And the sole purpose of this is so that the bed where the client is lying can be adjusted both upwards and downwards to basically adjust the view. But also more importantly, to control the movement of the transducer as well as the ultrasound probe. So once the transducer is either lowered or maybe raised, the beam also changes, and also the focal point you can be able to adjust based on, because you realize maybe you might encounter maybe a patient who is maybe more obese or one who has fibroids in the posterior wall. That definitely means that you have to adjust the depth and even the lateral movements of the transducer, which can be achieved with that panel. I think the other question was with regards to anterior and posterior fibroids. And that is an important consideration, especially in terms of consideration for safety, because for women who are not obese or those who are quite lean and maybe they have anterior myomas, they are a lot easier to treat than fibroids which are in the posterior wall, because it means that the ones which are in the posterior wall, because the patient is lying prone, you probably have to shoot the beam closer to the sacral area, which in a way is one of the risky areas, because if energy dissipates towards the sacral plexus, for example, or even the nervous tissue there, then sometimes clients can present maybe with sciatica or pains. So the anterior fibroids are a lot easier to treat, and of course you can adjust the depth of the beam based on how you raise the transducer, either up or down, and left and lateral movements to be able to target the lesion. One of the advantages of this technology, as you realize, is it's infused with ultrasound within it. So you can be able to see your beam and also see the focal point and see the fibroid, so that regardless of the fibroid that you want to treat, you can be able to target and see that your thermal knife or your ablative point is actually within your target tissue. And that helps in terms of getting both the anterior and posterior fibroids. There's a question you asked about the acoustic pathway and the bladder. So, and I think it's actually a brilliant question, because maybe one of the things I didn't mention is that when we do this procedure, of course, for about a week prior, we've sort of discussed with the client about bladder training, number one. But even during treatment, we catheterize these clients for one main reason. We can be able to adjust the size of the bladder. That's number one. We can either infuse some saline into the bladder or even release, depending on how it displaces the uterus and maybe where the fibroids are. Sometimes you are forced to use something called a water balloon. I think I didn't have it on the presentation, but it's basically a plastic bag that contains water to be able to displace the bladder and maybe create a longer channel. Yeah. Oh yeah, the question about ectopic. So generally, I think maybe there is promise for that, but so far it's been used for mainly solid tumors, and ectopic has mixture of RPOC, some blood, and maybe there is still hope for it, because especially we have seen it's been used for cesarean scar pregnancies, which in a sense are actually ectopic pregnancies. Yeah, and they are also highly vascular pregnancies. So I think there is probably hope for that. I think maybe the only reason I would imagine it's not commonly used for that is majority of times when you're dealing with ectopic pregnancies, I think there's also a time element in terms of maybe a risk of, say, rupture or the clinical profile of the patient, as compared to, say, things like fibroids or adenomyosis, for example, or even endometriosis, as you've seen, because those ones are mainly elective. They wouldn't really compromise the life of the patient, because even after ablating, you'd still need maybe a few weeks, a few months for it to actually shrink. Yeah, Prof had a question, I think.
Okay, let me give you a scenario. Say you have this 42-year-old, maybe some fertility, well, maybe caused by those uterine fibroids reaching on the fallopian tubes, and she comes to you. She's reluctant to undergo the knife. She comes to you because she has heard of this new innovation in management of fibroids, and so she wants this hive and to shrink those fibroids so that she can be able to conceive. And you realize that her fertility window is actually very short, at 42. What would you tell her about the rate of shrinkage of these fibroids? And when can she actually plan to have this pregnancy?
Okay, I know sometimes they are challenging. All conditions are not usually the same. I know others are easier to treat than others. But even so, maybe one of the important considerations is, number one, the size of this fibroid that we are talking about. Also, I think location in relation to the fallopians, because maybe of risk of corneal blockage. But also more importantly, and I think fundamentally for Hifu, is the vascularity of the fibroid, because when we conduct the MRI for the pre-procedure evaluation, we are looking mainly at how vascular is this fibroid, because the vascularity is also what will determine how fast these fibroids can shrink. So like, for example, for grade 3, FUNAKI 3 fibroids, which are considered to be highly vascular fibroids, and you can see it on the MRI, the shrinkage is a lot slower than the grade 1 and grade 2. And as you can see, even in the most, sometimes even in the most promising situations, the client has to be patient for maybe 3 to 6 months for them to actually appreciate significant shrinkage of the fibroid. So a 42-year-old woman, maybe someone who wants to conceive within, say, 6 months, maybe, or the window is really short. And I'm sure they also have other confounding factors, maybe ovarian reserve and other problems. So maybe we would still need to discuss with the patient, you know, in terms of time that she's willing to wait. Because one of the things that we tell clients who have fibroids and they want to undergo this procedure is at least they have to be willing to be patient. The benefits are there to see, yes, but they also have to be willing to be patient to appreciate the resolution of symptoms. But you see, maybe if a lady is 42 years old and she feels like 6 months is a long time to wait for them to shrink, then maybe you might consider to tell her a different option altogether. Because at the same time, as much as you're offering a solution, I think you have to be truthful to the patient that we have done the ablation, but you also have to wait for the fibroids to shrink. And I think that's why also this technology favors a lot younger women, you know, 20s, 30s, who also have some window. They can wait for the resolution and possibly conceive later.
Okay, thank you, Dr. Maina. I also have a concern. So, is the procedure painless? And also, why does the patient has to abstain for 3 days before the procedure? Does it mean that a 1 week, 4 days pregnancy is okay for the procedure? Or what is so specific about these 3 days? Then, I also have some concern. Can this HIF be done during any phase of menstruation, or there are luteal and proliferative, and it's likely that during proliferative phase the fibroids increase in size. So is there any concern, or is there anything that can be done for that HIF procedure to be performed during proliferative phase when the fibroids are increased in size, or the phases are okay regardless?
Okay, so maybe let me start with the first question. So generally, of course, we want to do this ablation for women who have zero chance of being pregnant to start with. And also the other thing is we prefer to treat, or rather the part of the protocol is to treat when the client is also not bleeding or having vaginal discharges, as well as, you know, infection. So those are considerations that we put into place because
we do not, number one, to start with, it interferes with the transmission of ultrasound waves, and you want to be sure that you have correct view of the fibroids. But also more importantly, you don't want to give energy to a pelvis that maybe has some possibility of infection. I think the other thing you're asking is about the phases of the cycle. It's not really, the phase of the cycle doesn't really preclude treatment. The only thing is that the patient should not be having bleeding during treatment, because as you've seen, the client usually is lying under a degassed water tank. So one, you don't want to contaminate. This degassed water is degassed in a plant which is just maybe adjacent to the machine. So you don't want anything that would cause, would interfere with that degassing. That's number one. And then secondly, you do not want anything that interferes with the acoustic window that you're trying to establish. So as long as the patient is not bleeding, they can be treated during any phase. It's not a reason to preclude treatment.
Is your procedure painless?
Oh, okay, good question. I was hoping you don't ask that question. Yeah, but generally what clients usually experience is mainly cramping, because you're hitting the fibroid, which has some vascularity. So you're causing some necrosis in it, ischemia, necrosis. So that is to say that they're going to experience some low abdominal cramping or some pain. But this is something amenable to ordinary pain medication, the NSAIDs, paracetamol. Actually, after treatment, and I think it's a good thing that you asked, we discharge the patients on antibiotics and some analgesics, maybe for 3 to 5 days. On the skin, usually we want the client to tell us whether they're experiencing any burning sensation or any pain, because as you can see, there's some energy you are giving. It's only that it is in low quantities away from the focal point, but there's still some energy, and you don't want to take chances with maybe causing injury to the skin, for example. What Dr. Ecole had asked also about, especially the posterior fibroids. If you have big posterior fibroids, then you also have to be very careful when you're giving the energy, because you don't want to cause injury to the nerves, because if you injure the nerves, especially the lumbosacral plexus, then you're likely to experience some maybe back pain or maybe some form of sciatica. That said, the patients are usually put under some light sedation to, number one, reduce maybe the pain they feel, and also to reduce movements during treatment, because they have to remain still to avoid the thermal the thermal knife from hitting an organ that is not intended. But there can be some discomfort. On a scale of 1 to 10, maybe about 4. We are collecting some data on how our patients react to the procedure. So far, maybe you could say the pain or the discomfort ranges from about 4 to 5. And we manage it with analgesia, and also just giving rest. And giving rest means, you see, when you move the beam by adjusting the level of the transducer, it focuses at a different area. When you lower the transducer, then the focal point is away from maybe a particular area that is feeling pain. So you lower the transducer, you lower the probe, and also you withhold energy for a few seconds actually. And the patients usually are able to have resolution of that. Yes. Yes, this is what I started by saying. Generally, we want to avoid any discharge within the vaginal canal and any infection, as well as issues around pregnancy. Generally. Sure.
Quick one. So how soon can somebody get retreatment? Like what is the interval between maybe one treatment, and is there a maximum number of treatments a patient can incur? Last thing, what is the cost?
So there is no maximum number of treatment cycles. Majority of women, at least from the data that I have come across, because hundreds of thousands of women have been treated elsewhere. Maybe here in Kenya we still have low numbers because it's not very old, but generally most patients require a single treatment, because when you're treating, one of the beautiful things is that you can tell, before the patient leaves the table, you can tell how much of this fibroid you have ablated. If you ablate less than 80%, then you haven't really achieved the objective to start with. However, highly vascular fibroids, or maybe patients who have multiple fibroids, you can discuss with them to do
an interval ablation later, but that also puts into account the fact that once you do the ablation for one fibroid or for maybe the likely significant fibroid, then they could have to wait maybe for 3 months or 6 months for that to shrink. I'll give you an example. In February, we had a client who had fibroids all over the uterus. The uterus was actually almost at the level of the liver, but there was only one big dominant fibroid which was lying in the pelvis. So the discussion with this client was, we are sure this big fibroid is most likely what is causing the symptoms, but you also have other multiple fibroids. The only thing is that these other fibroids are also in a risky area because now they are near viscera. So we discussed with this client, we ablate this big fibroid, we give it time. Once it shrinks, of course, the uterus size is also going to reduce. And then we can reevaluate through simulation to determine how safe it is to treat the rest of the fibroids. So there's no cut in terms of the maximum number of sessions that you could treat, but you can always have repeat sessions for those patients who have either highly vascular fibroids or maybe multiple fibroids which are not able to ablate in one sitting. And the beautiful thing is even repeat treatments are still safe to do without exceptionally added risks. Maybe the only thing could be maybe cost. And that brings me to the question of cost. So the cost of treatment, this is a challenge I think we had even during KOGS, for those who attended KOGS, or people wondering, is it too expensive or not? But we tried to bring this cost to competitive market rates, which compares with other modes of treatment, for example, myomectomy, laparoscopy. So our price range is about for 50,000 to around 500,000. This sometimes varies, and I've seen it happen on clients who are maybe insurance payers, cash payers, as well as sometimes also clients get discounts appropriately. But the beautiful thing also is that now we have many insurances. That I think we have close to 10 insurances that have come on board, and this is after the realization that majority of clients who are insured by these insurers are willing to undergo this procedure. The barrier is the payment. So now most insurances are already volunteering to come and on board the procedure. And in the last 6 weeks or maybe 2 months, we've seen a growth in terms of clients who we have either ablated or have scheduled for ablation. Yes. Okay. Thank you for listening to me. We can meet at the booth there.